Hi guys, good morning. So today we are going to discuss our next topic, that is about the orthodontic diagnosis. So starting with the definition or the introduction, the orthodontic diagnosis, it basically deals with the recognition of the various characteristics of the malocclusion. So the orthodontic diagnosis, it has the two aids that are the essential, or the two diagnostic aids that are the essential diagnostic aids and the supplemental diagnostic aids. The essential diagnostic aids, these are very important. You have to take these essential diagnostic aids of each and every ortho patient. So starting with the first essential diagnostic aids, so these are the clinical aids that are considered very important for all the important cases or for all the orthodontic cases. And the essential diagnostic aids, they include the case history. The case history, you have to take the case history thoroughly, right? Asking the name, age and sex and address and occupation of the patient. And very important, the chief complaint. The chief complaint is in the patient's own words. Right, next are the clinical examination. It should be extraoral and it should be intraoral. Next are the study models. When the ortho patient came into your clinic, after taking the detailed case history and the intraoral and the extraoral clinical examination, then you have to take the impression, port the cast, and these are your study models, which are again helpful for your model analysis. Fine. Certain radiograph if necessary, like the periopical radiograph, the bituing radiograph and the panoramic is must. And the facial photographs. Facial photographs are important for your pre and post treatment cases, to see the profile of the patient before the treatment and see the profile, the nasolabial angle, the lips and the dentition after the treatment, right? And the supplemental diagnostic aids, these are the certain aids that are not essential in all the cases, but these are essential in some particular cases or that require the specialized equipment. The supplemental diagnostic aids, they include the Ceph radiograph, occlusion intraoral films, selected lateral jaw, the cone shift technique, the electromyographic examination of the muscle activity. Next is the hand wrist radiograph. So hand wrist radiograph, we are usually take the hand wrist radiograph to knowing that the patient is in the growing age or in the non-growing age. In the growing age, we are various appliances we are giving it the growing age, like the myofunctional appliances. We do expansion of the upper arch in if the patient is growing, and in the non-growing patients we can do the fixed ortho. So for that you need to take the hand wrist radiograph of the patient. The endocrine test, estimation of the basal metabolic rate, diagnostic setup and the occlusiogram. So these are the supplemental diagnostic aids. Starting with the general examination, you can check for the height and the weight, so that they provide a clue for the physical growth and the maturation of the patient. The gait, it means how the patient walks or how the patient enters into your clinic or your hospital. The abnormalities of the gait are usually associated with any kind of the neuromuscular disorder that may have or may not related to the dental correlation. The posture in which the patient stands, the way the patient stands, it is an abnormal posture. It can predispose a number of malocclusion due to the alteration in the maxillomandibular relationship. So next is the body build, that is the physique. So in this we have three types of the physique. We have the aesthetic, in which person having a thin physique and have a narrow dental arches. Very important. Plethoric, it means the patient is obese, healthy with the large square dental arches. In this, patient having a narrow dental arch, that is the U-shaped dental arch, and the V-shaped dental arch. In this, the patient having the V-shaped dental arch. In the plethoric, the patient is obese and has a square dental arches. And in the athletic patients, the patient which are having a normal build, they are either thin, they are neither thin nor obese, they are having a normal dental arch. Normal is mostly ovoid dental arches. Fine. So aesthetic is thin physique having a V-shaped arch or having a narrow dental arches. Plethoric, the patient is obese having a square shaped dental arches. And athletic, it is neither thin nor obese and having a normal dental arches, that is mostly ovoid. We usually follow the ovoid dental arches or the ovoid kind of wires in our ortho treatment. Very important classification, the Sheldon. Important, commonly asked MCQ, that the Sheldon has classified the general body build. So if a question comes, who has given the classification of the body build, so your answer should be Sheldon, commonly asked MCQ. Right? So in this we have three types of the body builds: the ectomorphic, the mesomorphic, and endomorphic. Ecto, it means tall and thin. The meso, it means average, neither tall nor short. Endomorphic means short and the healthy or the stout physique or the obese physique. Important. Now after this, coming on to the extraoral examination, first of all, the shape of the head, that is, we usually take the cephalic index. Cephalic index is equal to the maximum skull width. This is the maximum skull width by maximum skull length. This is the skull length. This is what the cephalic index is. Fine. Into 100. Fine. This is the formula of calculating the cephalic index. Now it has the ratio of 76 to 81%. Fine. So in this we have three types of the head. The mesocephalic, it means the average shape of the head. It possesses a normal dental arches. So mesocephalic, if it falls in between the ratio of 76 to 81%, then you can say the patient has a mesocephalic head. If dolichocephalic, it means long and narrow head. They have a narrow dental arches or V-shaped dental arches. The dolichocephalic is when the percentage of the cephalic index, it is less than that of 81%. Then you can say the patient having the dolichocephalic head. Next is the brachycephalic. It means broad and the short head. Right? So the brachiocephalic, it means when the patient is having more than 81% of the ratio. In that case you can say that the patient having the brachiocephalic head. Mesocephalic, normal. Dolichocephalic, long and thin or long and narrow. Brachycephalic means broad and short. This is the normal ratio. The cephalic index was given by the Martin and Seller in year 1957, commonly asked MCQ. Next is the facial form that we call as the facial index. So you can calculate the facial index by the height upon the bizygomatic width, fine. So in this is the height is from the nasion. This is the point between the two eyebrows. This is the nasion to the gnathon onto the menton. This is the length, and this is the width, that are the bizygomatic width. Fine. So this is the facial index, that is the height by the bizygomatic width. So the ideal ratio is 84 to 88% of the facial index. The facial index and the cephalic index, both the indexes, these are given by the Martin and Seller in year 1957. Again important. Right. So in this, likewise, like that of your cephalic index, the facial form or the facial index also having the three kind of faces. In this we have the mesoprosopic, it means the patient have an average or the normal facial form. So if the ratio is between 84 to 88%, then you can say the patient having the mesoprosopic face or the facial form. Europrosopic means the face is short and broad. So in this, if the average is less than 84%, then only you can say that there is the patient having the europrosopic facial form. The leptoprosopic means the long and the narrow facial form. It means when the ratio is more than that of the 88%, then you can say the patient having the leptoprosopic facial form. Right? Again, important. So after this, next is the facial symmetry. So the patient's facial symmetry, it is examined to determine the disproportion of the face in the transverse and in the vertical planes. So the gross facial symmetry, it can occur in case of any kind of congenital defect. There is always the gross symmetry of the face. This is the normal face, this is the gross symmetry, this is the facial asymmetry, fine. So you can find it in case of the congenital defect in the hemifacial or the hypertrophy, in the unilateral condylar ankylosis and the hyperplasia. Now coming on to the profile, very important. See, in this we have three types of profile. We have straight profile, we have convex profile, and we have the concave profile. How to determine the profile? See, this is a line which are joining the forehead of the soft tissue. This is the glabella, which is the most prominent part in between your eyebrows, and this is point A, which is the deepest in the curvature. Fine. So this is the point from the glabella to point A. This is one line, and a line joining point A to, this is the pogonium, which is the most prominent portion on the chin. See, the line joining the most prominent part of the forehead to point A, and from point A to the pog, that is the most prominent part of the chin. So by this line you can identify which kind of profile the patient have. Right? So in case of a straight profile, the two lines, that is this line from the forehead to point A and from point to pogonium, the line, it should be straight, then the patient having a straight profile. But if the line joining the forehead to point A is straight, but line joining the point A to pogonium, it is slightly deviated, then this is convex facial profile. And convex facial profile you will always see in case of class 2 division 1. Why? Because in class 2 division 1, as I have already told you, that in this case patient having a proclined maxillary incisors. So in that case, see, if the patient having a proclined maxillary incisor, so in this lips should be incompetent, lips will not close, there is no lip seal. So in this, the line, it should be like this due to the proclined maxillary incisor. So the profile is convex in case of class 2 division 1. Important for your MCQ. Fine. Next is the concave facial profile. Concave, the line joining from the forehead to point A and point A to your pogonium. In which cases your pogonium, your chin is slightly forward in cases of class 3. In class 3 you will find the patient having the concave profile. Why? Due to the prognathic mandible. So your line, it should go like this. following a concave pattern. Fine. So in your straight profile, if a patient having a normal face, convex profile in class 2 div 1 patient. Why? Due to the proclination of the maxillary anteriors. Concave profile in class 3 patient. Why? Due to the prognathic mandible. Right? So after this, next is the facial divergence. So the facial divergence, it is defined as an anterior and posterior inclination of this lower face. Right? So the anterior diversion, in this, a line, it is drawn between a forehead to the chin straight away. If the chin, it is lying anteriorly towards the chin, so it means the patient having an anterior diversion. See, the facial divergent, it is always dependent upon the position of the chin. First of all, when you draw a line from a forehead to the chin, if the chin is present in a normal position, then the patient having a normal divergence. If the chin, it is placed slightly forward, then the patient having an anterior divergence. It is commonly seen in case of class 3 patient, in which your chin is slightly forward. And posterior divergence, when you draw a line from a forehead to the chin, if the chin, it is lies posteriorly, then it is called as posterior divergent. Right? Next is the straight or the orthographic profile. When you draw a line straight away from the forehead to the chin, if a line is perpendicular, the line between the forehead and the chin, it is straight or perpendicular to the floor. This is the floor, and this line, this straight line, is perpendicular to the floor, then you can say the patient having a orthographic or the straight divergent. Next is the evaluation of the facial proportion. So in this, a well proportioned face, it can be divided into the 1, 2 and 3 equal halves by using the 4 horizontal plane. Like number 1, first is at the level of the hairline, this one. Second is at the supraorbital ridge. Third is at the base of the nose, and fourth is at the inferior border of the chin. Fine. So within the lower face and the upper lip, this is the lower face, and within the upper lip, it occupies 1/3 of the distance, while the chin, it occupies the rest of the space. So this is the 1/3 distance, that is the lower face, the upper lip, it occupies only the upper lip, it occupies the 1/3 of the distance, while rest is occupied by the chin. So all these 3 proportions, these are divided in an equal proportion in a normal individual. Right? But in case of the hyperdivergent patient, the lower facial height, basically in a normal individual, the upper facial height and lower facial height, the ratio is 1:1. That is, in terms of ratio, it is 1:1, but otherwise it is 45:55. Right? So in case of the hyperdivergent patient, the lower facial height, it is increased in case of hyperdivergent patient. Fine. So after this, next is the transverse facial proportion. See, very important. In this, you can draw basically the facial proportion or the face, it is divided into the 5 equal half. So you can draw a line from the inner canthus, 1 line, this is the 2 line. Third line is from the outer canthus, this is from the outer canthus. These 4 lines divide the face into the 5 equal parts. But for this, you have to keep in mind that the width of the nose, it is parallel, or it is same way as that of the inner canthus of the eyebrows. Fine. Very important, the width of the nose, it should follow or it should be equal as that of the inner canthus, while the width of your mouth, it should be equally to the interpupillary distance. These 2 points are very important. Right? So these 2 lines, it should pass the width of the nose, it should the 2 lines, it should be passed from the side of the nose and from the inner canthus, and the 2 points commonly asked, which are commonly asked as an MCQ, that in this, the width of the nose, it should be same as that of the inner canthus, and the width of your mouth, it should be same as that of your interpupillary distance. Right? This is what the transverse facial proportion is. So these 2 lines, it should pass from the side of the nose. So after this, next are the examination of the lips. So in this, the upper lip, it covered the entire labial surface of the upper anterior except for the incisal 2-3 mm. The lower lip, it covers the entire labial surface of the lower anteriors and 2-3 mm of the incisal edge of the upper anteriors. Important. Now in this, very important is the examination or the classification of the lips. So in this, we have 4 types of lips. First is the competent lips. These competent lips, it means the patient having a proper lip seal. There will be no interlabial gap when the patient closes its mouth in rest position. Fine. So in this, the lips, these are particularly seen in case of a straight profile. In a straight profile patient, you can see a patient having a proper lip seal. Yes, you can also see the patient having a class 2 division 2. In this case also, the patient having a competent lip, there is a proper lip seal. Second are the incompetent lip. It means the patient is not able to close its lips properly. There is no proper lip seal. Why? It is might be due to the hypotonic upper lip, which means the short upper lip. Due to the short upper lips, it does not form a seal in a relaxed position. That is why it is called as an incompetent lips. Right? Very important, you can see the incompetent lips in case of class 2 division 1. Commonly asked MCQ. In class 2 division 1 patient, there will be no proper lip seal due to the hypotonic upper lip. Third are the potentially incompetent lips. It means they are normal lips that fails to form a lip seal due to a proclined, these are proclined upper incisors. Due to the proclined upper incisor, they are the normal lips that are failed to form a lip seal. And next are the fourth one are the everted lips. These are the hypotrophied lips with a weak muscular tonicity. Very important, commonly asked MCQs about the lip seal. So this is just a lip seal, or you can say the lip step, which was given by the Korkos. So in this, a positive lip means this is normal and there is a positive step. The lower lip, it is slightly forward than that of your upper lip, then you can say it is a positive lip step. Next is the negative lip step. The positive lip step, it is usually seen in case of class 3 patients, while a slightly negative lip step, it is in which there is almost similar, the upper and the lower lips are almost similar, but the upper lip, it is 0.5 anterior to the lower lip. Fine. And next is the negative lip step, in which the upper lip, it is far more forwardly placed than that of the lower lip. So it can be seen in case of class 2 division 1 in case of proclined anteriors. Right? So this lip step, this classification was given by Korkos. Right? So next is the assessment of smile. Very important, commonly asked MCQ. See, in this we have two types of smile. We have the posed smile and we have the unposed smile. The posed smile, what is the difference between the two? The posed smile is the smile when we click any passport size photograph. That smile, it is called as, when we give the smile for any kind of photography, like for the passport size photograph, this is what we called as posed smile. And the unposed smile is the natural smile. Natural smile. It is also called as Duquesne smile. Fine. So your MCQ which was previously asked is about the posed smile, which is the photographic smile. Right? So next we'll talk about the smile arc. So smile arc is of two types, the consonant and the non-consonant smile arc. There are two types of smile arc, the consonant and the non-consonant. Now what is the difference between a consonant and a non-consonant? See, these are the incisal edges of the upper incisor, and this is the lower lip. This is the lower lip. So in this, the smile arc, it is defined as a relationship of the curvature. So this is the curvature of the incisal edges. These are the, see, I'm drawing it again. These are the incisal edges, and this is the smile arc. So the smile arc, it is defined as a relationship of a curvature of a incisal edges. These are the incisal edges to the curvature of the lower lip. Fine. So in an ideal smile, the incisal edges of the maxillary incisors, in an ideal smile, the incisal edges of a maxillary incisors, these are always parallel to the curvature of the lower lip. This is what we call as smile arc. Right? So next is the buccal corridor. So this is the buccal corridor. So it is a distance between the maxillary posterior teeth and the inside of the cheek. So this is the buccal corridor, the ratio of the intercommissural width, which is divided by the distance from the first premolar to the first premolar, from first premolar to the first premolar, and it is ideally it is 13% of the intercommissure width. Important, 13%. Right? Now next is the examination of the nose. So in this, the nose to a large extent, it contributes to the aesthetic appearance of the face. Or the nose size is normally, the nose is the 1/3 of the total height. Fine. So the nasal contour is the shape of the nose. It can be straight, it can be convex, it can be crooked. It is the nasal contour. This is, it can be straight, it can be crooked, or it can be convex. The nostrils, these are oval and should be bilaterally symmetrical. Right? So in this, we usually check for the for this we usually check for the nasolabial angle. So the nasolabial angle is the angle which is formed between the nose and the lip. It means one line it is drawn from the base of the nose, and one line it is drawn from the upper lip. So this angle, it is called as the nasolabial angle. Fine. So the ideal angle or the normal angle is 110 degree. So if it is more than that of the 110 degree, the patient having an obtuse nasolabial angle, see, normally is 90 degree. Fine. If the patient having less than that of the 90 degree, it means the patient having an acute nasolabial angle. If the patient having an more than 90 degree, patient having an obtuse nasolabial angle. The acute nasolabial angle is always present in case of class 2 division 1 because of the proclination. Next is the examination of the chin. So this is the mentolabial sulcus. So the mentolabial sulcus, it is the concavity which is, this is the concavity which is formed between the or below the lower lip. So in this, the deep mentolabial sulcus, it is seen deep, is always seen in class 2 division 1, fine, due to the retrognathic mandible, fine. So the hyperactive mentalis, it is seen in case of class 2 division 1 cases. And the chin position and the prominency, the prominent chin, it is usually associated with the, if the chin is prominent, it is usually seen in class 3 malocclusion. Why? Because of the prognathic mandible, fine. So next, we have already discussed the nasolabial angle. It is an angle which is formed between the lower border of the nose and the line connecting the intersection of the nose. And this angle, it should be 110 degree. It reduces in the patient with the procline upper incisor. As I've already told you, it is acute angle in case of class 2 division 1 in case of prognathic maxillary incisors, fine. So next are the intraoral examination. So any abnormality of the tongue, it can upset the muscle balance. A patient whose tongue can reach the tip of the nose, it is said to have a long nose. So the lingual frenum, it should be examined for the tongue tie. Next is the examination of palate. In case of class 2 division 1, the palate is deep, right? So in dolichocephalic patients, the palate is deep, the patient having a long and narrow face. The presence of the swelling in the palate, check for the mucosal ulceration and indentations. Presence of any cleft in the palate. The third rugae, it is usually in the line of the canine. So this is the important part which is related to the ortho. Next is the examination of the gingiva. Gingiva should be examined for the inflammation, recession, mucogingival, poor oral hygiene, but in case of mouth breathers or in case of mouth breathing habits, you can always find that this is marginal gingivitis. Why? Because the patient who breathes from the mouth, the gingiva is always dry, right? So in the it causes the marginal gingivitis or anterior gingivitis. Commonly you have seen in the patients having a mouth breathing habit. Due to the dryness of the mouth, it is caused by the open lip posture, and in that case you can give the oral screen as the treatment. And to avoid the dryness, you can also apply the petroleum jelly. Right? So next is the examination of the frenal attachment. Very important in the ortho diagnosis. Why? Because of the high frenal attachment, it can cause the midline diastema. Right? And you can check for the midline diastema by the Blanch test. Fine. So the abnormal frenal attachment, these are particularly diagnosed with the help of the Blanch test. Important. So after this, next are the supplemental diagnostic aids. So supplemental diagnostic aids we have already discussed. These are the Ceph radiographs. These are the occlusal intraoral films, the cone shifted technique, electromyography or the Kessling diagnostic setup. And in this We can also do the endocrine test, the diagnostic setup, and occlusograms. It is not very important, but in some cases or in special cases you can go for the supplemental diagnostic aids. So next are the model analysis. So the model analysis, it is the study of the dental cast which helps to study the occlusion, dentition from all the 3 dimensions and analyze the degree and the severity of the malocclusion and derive the diagnosis and the treatment plan. See, in this, your upper cast should always parallel to the lower cast. These are the 2 important points. And your upper cast, it should always parallel to the floor. I repeat, your upper cast should always parallel to the lower cast. Your upper cast should always parallel to the floor. These 2 points are important for your MCQ. Coming on to the classification, again permanent dentition and the mixed dentition model analysis. So in permanent dentition, we usually follow the bonds, the caries, Ashley-Ho analysis, arch perimeter, Linderhart, Korkhaus, boltons, peck and peck. And in the mixed dentition, Moyes mixed dentition, tanakajohnson, Nance mixed dentition, radiographic, that is Hokaba's mixed dentition analysis. Now out of these, most commonly used are the bonds analysis, the caries analysis. Caries analysis, if you are performing the model analysis on the lower cast, then you can say it is caries analysis. Ashley-Ho analysis, arch perimeter analysis means when you perform the caries analysis or the model analysis on the upper arch, then you can say it is the arch perimeter analysis. And 1, 2, 3, 4 and 5th one is the boltons analysis. So these are the 5 analyses which are usually we done in the permanent dentition. So in case of the mixed dentition, we usually prefer the Moyes dentition and the Tanaka-Johnson. Fine. So starting with the caries analysis. So the caries analysis, it is usually helps in determining the extent of the discrepancy, and it is related, the caries analysis, it is related to the arch length. Please note it down, arch length, don't get confused. So the caries analysis, it is performed on the lower cast, and if it is performed on the upper cast, then it is called as arch perimeter analysis. Very important, commonly asked MCQ. Fine. The caries analysis, it is usually done to check for the arch length. It is determine the extent of the discrepancy. If it is the caries analysis, if it is performed on the lower cast, it is called as the caries analysis. If it is performed on the upper cast, it is called as the arch perimeter analysis. So the arch perimeter analysis, we usually prefer from the anterior surface of the molar. Fine. So in this, we usually take a brass wire, soft brass wire. This is the soft brass wire we usually take to measure the arches or the arch length. So this one is the normal. So in this, the anterior in this are well aligned. So in this, the soft brass wire, it should be passed over the, it is passed anterior to the molar, and it is passed over the buccal surfaces of the premolar and follows a contour by passing on to the incisal edges of the anterior, then again passes on to the buccal surfaces of the premolars and continues to the other side. So this is in case of a normal arch. And if the arch or your teeth are proclined, so in that case, starting with the anterior portion of the molars, the wire should pass over the buccal surfaces and of the premolar, and it should pass on the cingulum, from the cingulum area of the anterior teeth. Why? Due to the proclination of the incisor. In that case, you can pass the brass wire over the cingulum areas and continue to the other side. While in case of the retrocline, these in case of the class 2 division 1, and in case of the retrocline maxillary incisors, so in that case the brass wire, it should pass over the labial surfaces. It should pass over the labial surfaces of the anterior. This is in case of class 2 division 2. Fine. So second point, this is the determination of the arch length. Second point is the determination of the tooth material, the TM. So in this you have to measure the mesodistal width of each tooth, starting from the second molar to the second molar. So this is the tooth material. Now coming on to the determination of the discrepancy. So in this, the discrepancy, it refers to the difference between the arch length, this length, you can measure this length, minus your tooth material. So this is what your caries analysis is. Now after this, coming on to the interpretation. So the arch length discrepancy, if the discrepancy is lying between 0 to 2.5 mm, then you can go for the proximal stripping. Proximal stripping is done with the help of the proximal stripper. It is just a stainless steel strip with a cutting edge of the stainless steel, either on both sides or on one side. And this proximal strip, it is usually used in case of the interproximal area of the two teeth to gain the space. Fine. So proximal stripping, it can be carried out to reduce the minimal tooth material. In that cases, you will perform the proximal stripping, in which you cannot afford extracting a premolar or extracting any tooth. So in that case, you can go for the proximal stripping to gain the space. Fine. If the ratio, it lies from the measurement, it lies from 2.5 to 5 mm, then you can extract the second premolar. And if you require the space greater than that of the 5 mm, then you go for the first premolar extraction. If you need the space of about 0.5 mm, go for proximal stripping. If you need the space of about 2.5 to 5 mm, go for second premolar extraction. If you need the space of more than 5 mm, go for first premolar extraction. Fine. Now second model analysis is the Ashley-Ho analysis. So this is basically used to determine the arch width. The case analysis for the arch length, and this is for the arch width. So this is how considered the tooth crowding to be. It may be due to deficiency of the arch width rather than the arch length. So this so the Ashley was the one who found the relationship which exists between the total width of the mesodistal diameter of the teeth anterior to the second permanent molar and the width of the dental arches in the first premolar region. See, in this determination of the tooth material, it means you have to calculate or you have to measure this mesodistal dimension of each and every tooth, but ranging from permanent second molar. Fine. So in this, the mesodistal width of all the teeth anterior to the permanent second molar, like from the first molar to the first molar, you have to measure the mesodistal width of all the teeth from first molar to first molar. Fine. Next is the determination of the premolar diameter. So it refers to the distance of the arch from the tip of the buccal surface. This is the tip of the buccal surfaces of the first premolar. So the PMD, it is usually, we usually calculate the buccal surface. This is the, these are the first premolar, these are the second premolars. So in this, the PMD, that is the premolar diameter, we usually take from the buccal surfaces of the first premolar of both sides. Fine. Next is the PMBAW. So in this, we usually measure the PMBAW with the help of a divider. So you open the divider, place the two ends of the divider into the canine fossa. You can feel there is a depression over the canine. So put these 2 points of the divider in that canine fossa and measure this width. Right, so now you have the total tooth material, you have the PMD, you have the PMBAW. See, if the PMBAW, that is the premolar basal arch which you have measured from the canine fossa to canine fossa, if it is more than that of the PMD, premolar, which you have measured from the buccal cusp tip of the first premolar, if the PMBAW is more than that of the PMD, there is an indication of the basal arch which it allows the expansion. In this, we need to expand the arch of the premolars. If the PMD, that is the premolar basal arch, the premolar diameter, it is more than that of the premolar basal arch width, it is usually done, or in this case the contraindication, it is contraindicated for the arch expansion. In that case you will not go for the expansion. But if the PMBAW is more than that of the PMD, in that case you need an arch expansion. Move the teeth distally and extract some of the teeth to compensate. If the PMBAW into 100 divided by the total tooth material, this is, so in this, if you suppose the value of your PMBAW is this much, suppose n, into 100 divided by TTM. So this is the value which you have, which with this value is basically decides whether your case is go for the extraction or for the non-extraction. So in this, if it is usually the ratio lies between 37% to 44%. If the ratio, if the PMBAW it is 37% or less than that of 37%, in this case you will go for the extraction. If the PMBAW it is more than 44 or it is 44, in that case the treatment, in that case you will treat that case by non-extraction, by not extracting any tooth. And if the PMBAW it lies between this ratio, it lies between 37 to 44 degree, 37 to 44%, this is what we called as borderline case. In this case the extraction may or may not be planned, whether this case go for the extraction, whether this case goes for the non-extraction. So this is the third one, is the borderline case. Important interpretation for your MCQ. So after this, next is the Phans analysis. So Phans analysis was given by Pont in year 1909. It proposed a method of determining an ideal arch width in the premolar and in the first molar area, which is based on the sum total of the mesodistal width of the maxillary incisor. In this you have to consider the 4 maxillary incisor, their mesodistal width. These 2 points are important, that the ratio of the combined upper incisor width to the transverse arch, it is usually 0.80 in the premolar area, while it is usually 0.6 in the molar area. Fine. So this is the analysis. In this you need to determine the sum of the 4 maxillary incisors. Fine. And next is the determination of the measured premolar value. So the measured premolar value, you can measure it from the width of the arch of the premolar. It is from the, this is the distal pit of the upper first premolar to the distal pit of the upper first premolar. So this is the MPV, that is the measured premolar value. Coming on to the MMV, that is the measured molar value. So in this area, the mesial pit of the first molar and the mesial pit of the upper first molar. The basic difference is the MPV, the measured premolar value, in this you have to take the distal pit, and in the measured molar value you have to take the mesial pit. Fine. So in this way you can calculate the sum of the 4 incisors. This is the CPV, that is the calculated premolar value. In this you SI, it means the sum of the incisor, fine, multiplied by 100, and 80 is for the premolar value. See, we have already discussed 80 for the premolar and 64 for the molar. So you just need to divide it by 80, you will get the calculated premolar value. Same way, the sum of the 4 incisor into 100, and for the molar the value is 64, and this is the calculated molar value. Important interpretation or is that if the measured value is less than that of the calculated value, then it indicates for the arch expansion. Important. Fine. Next is the Bolton's analysis, very important analysis. We usually do the Bolton's analysis in each and every case of the orthodontic. So in this, the Wayne Bolton, he considered the ratio of the tooth material of the maxillary arch to the mandibular arch, that is the mesiodistal width of the upper and the lower teeth. Fine. So in this, the measurement is, you need to measure this is the mesiodistal width. The sum of the maxillary 12, it is from the first molar to the first molar. Sum of the mandibular 12 from the first molar to first molar. Sum of the maxillary 6 from the canine to canine of the maxillary. Sum of the mandibular 6 from the canine to canine of the mandibular. Then we need to calculate the overall value is for the molar to molar, and anterior ratios for the canine to canine. So determination of the overall value. So sum of the mandibular 12. So you need to calculate the mesiodistal width of all the molar to molar, mandibular molar into 100, then sum of the maxillary 12 divided by sum of the maxillary 12. The normal ratio or the overall ratio is 91.3%. Fine. And inference is, if the overall ratio is less than that of 91.3%, then the tooth maxillary excess, there is a maxillary tooth material excess. So the amount of the maxillary tooth material excess, it is determined by the formula, the mandibular 12, this one, into 100 by 91.3. This is used to determine the maxillary tooth material excess. Fine. And if the overall ratio is more than 91.3, then there is a mandibular tooth material excess. Same way, in that case, maxillary 12, the mesiodistal width of the maxillary 12, that is from molar to molar, into 91.3 divided by 100. Same way than that of the anterior ratio, that is the sum of the mandibular canine to canine, mesiodistal width of the canine to canine, into 100 divided by maxillary canine to canine. So the normal anterior ratio is 77.2%. So if the anterior ratio is less than that of 77.2%, so in that case there is a maxillary anterior tooth material excess. Same way, the mandibular 6 by 100 divided by 77.2. If the anterior ratio is more than that of the 77.2, the mandibular tooth material excess, it is mandibular tooth material excess. So the formula is maxillary 6 into 77.2 divided by 100. This is for the mandibular 6. Fine. Very important. Please note it down. Now after this, coming on to the mixed dentition, commonly used, the Moyer's mixed dentition. So it is based on the premise that there is a reasonably good correlation between the size of an erupted permanent incisor and the unerupted canine and the premolars. So this is because a person with a large teeth in the one part of the mouth will have a large teeth elsewhere also. Their development, it is controlled by the same genetic mechanism. Here is the lower permanent incisor. These are measured, and the mesiodistal width of the unerupted. These are the mesiodistal width of the unerupted upper and the lower canine and the premolar. These are derived from the chart. So this is the probability chart. Fine. So in this, step 1 is, in this process, the step 1 is the space required. So in this, measure the mesiodistal dimension of all the 4 incisors and calculate or sum data. Fine. So using the Moyer's probability chart, this is the Moyer's probability chart. Find the total mesiodistal width of the upper and the lower canine. So in the probability chart, the unerupted canine and the premolar, you have to measure the mesodistal width of an unerupted premolar and the canine by using the probability chart. Fine. Step 2 is the space available. So if the space is available, measure that the distance between the distal surfaces of the permanent of the space is available here. So for this you have to measure the distance which is present distal to the permanent lateral incisor and the mesial surfaces of the permanent first molar. The mesial surface of the permanent first molar. Fine. So the amount of the space left behind, this is what we called as the available space. So this is the probability chart to calculate the mesodistal width of the unerupted canine and the premolars. So in this last is the Tanaka and the Johnson analysis, which was given by Tanaka and Johnson in 1974. So they developed a method to predict the width of the unerupted canine and the premolar by using the width of the lower incisor. In that Moyer's analysis, we have to measure the width and by taking the probability chart into consideration. But in the Tanaka-Johnson, to predict the width of the unerupted canine and the premolar, you have to measure the width of the erupted incisors, lower incisors. So this method has a good accuracy. They have simplified the Moyer's 75% prediction table into the formulas. So the predicted width of the maxillary canine and the premolar is the sum of the mandibular incisor plus 11 divided by the 2. The predicted mandibular canine and the premolar, sum of the mandibular incisor plus 10.5 into 2. These are the two calculations. Fine. So guys, this is all about the diagnosis part. Please go through it once and try to make the notes. Thank you.